Hi, welcome. Thanks for being here and taking part in the discussion today. My name is Brian Bezick, and I work as a PA in respiratory medicine at the Terry Riley Health Centers in the Boise area of Idaho. If you've never been out here, it's a beautiful place and love to have you visit. Today is a time when we get to talk about asthma COPD overlap. And this is such a great topic because everything has changed with this over the last few years. If the last time you had anybody talk about ACO, asthma COPD overlap, if it was 7 or 8 years ago, then you maybe had one kind of set of understandings. If it was 4 or 5 years ago, completely different. And now where we are today is the thought about this particular condition is changed again. And now we have good consensus between the guidelines. And the first question I'll just kind of start with is it a thing? Is it a valid diagnosis? Is it important? And we're going to get to that, but I'll tell you this, it's very important. It's no less important than it has been at any time in the last few years, even though at this time, it's not being treated as a separate entity. It's not a third diagnosis, if you will, asthma, COPD, and then asthma COPD overlap or ACO. We don't have it as a distinct entity. It's simply a patient with both conditions. But that distinction, making it not a separate entity, that doesn't change at all the validity or the importance of this topic. So we're going to dive into this, and hopefully this is very helpful and kind of sets the stage. I also am a patient with alpha-1 antitrypsin deficiency. Kind of a side note, but it does relate in, and I'll hit this in a few slides. But alpha-1 is a condition that is a genetic form of COPD. It's something that is throughout my family. My mom, aunt, and uncle all passed away of complications related to alpha-1. I have moderate disease. I'm currently not on therapy, but it certainly is one of those conditions that kind of like asthma COPD overlap. If we're not thinking about it and we're not constantly at least considering it in a patient, we're going to miss it. And alpha-1 is one that's often missed, 6 or 7 providers or visits before somebody gets diagnosed accurately. So it is an interesting part of asthma COPD overlap, and I'm going to touch on that in just a minute as well. First thing we're going to do is just kind of set the stage and talk about the definitions of the two conditions. Asthma, when it's by itself, and that's the only condition, we think about the way Gina describes it, and you can see that they're a heterogeneous disease characterized by chronic inflammation, airway inflammation, and respiratory symptoms like wheezing, shortness of breath, tightness, and cough. All of these are persistent. Asthma often starts in childhood, not always. It can develop, patients can develop this as adults, but it is often a lifelong disease. It's not typically due to exposure to something. This may be part of an atopic patient's life. The second part is COPD, and we think about GOLD and how GOLD defines COPD, a common preventable disease, and it's very treatable. I like the fact they added treatable right in there. And it's characterized by persistent limitation of airflow, typically progressive, chronic inflammation and response in the airway to noxious particles, usually tobacco smoke. About 70% of the time, it is due to tobacco smoke. And exacerbations and comorbidities make this a very difficult disease sometimes to treat. COPD, asthma, two very distinct entities. And a patient could have asthma and then kind of over time morph into more of a COPD patient. Maybe an asthma patient smokes tobacco and they become an asthma COPD overlap. COPD, maybe you're treating a patient with COPD and you haven't really asked about their childhood or their history of allergic disease. Or maybe you notice they have some atopic dermatitis and it makes you think, could there be something more going on? These two entities, they exist separately. Asthma COPD overlap isn't a separate entity. It's just when a patient has both conditions at the same time. But it does change everything. And that's the important point. It's not a distinct entity, but it is so important. And just missing it for a patient and delaying the diagnosis can dramatically change the outcomes for patients. Now, when we think about how to describe ACO, both Gold and Gina describe it this way. We no longer refer to asthma COPD overlap as a syndrome. So it used to be asthma COPD overlap syndrome or ACOS, but no longer is it a syndrome. We emphasize these are different disorders and have common treatable traits and features. Asthma and COPD overlap, asthma and COPD can exist in the same patient. If the concurrent diagnosis of asthma is suspected in a patient with COPD, then asthma guidelines should be used. And that's kind of the key difference. And we'll get to it in just a second. The one big point here is that patients with asthma and COPD simultaneously, their treatment options are pretty much anything. It's a very diverse option because you have both conditions, and it can change our treatment options. So again, it's not a distinct entity, but its importance has never been more significant. The epidemiology, if you will, I love this quote. According to a case definition of ACO that has been widely promulgated, the syndrome is estimated to be present in 15 to 45% of the population with some type of obstructive disease. And the prevalence increases with age. So you can see that quote there. And it emphasizes that this is not an uncommon thing. If you're treating asthma and COPD, if you see that even on a fairly regular basis, as we do in most family practice and internal medicine practices, you're seeing this quite a bit. If you're going through a couple of weeks of seeing patients and this hasn't come up, we're probably missing them. Just like alpha-1 that I referred to a minute ago, it's just one of those conditions that if it's not top of mind, we miss it, and we miss opportunities to intervene. It is more common in older adults and in smokers, which I think that makes sense. It does contribute to significantly to healthcare costs, and it's under-recognized and frequently misdiagnosed. It's just missed. Patient comes in, maybe they're having an exacerbation of the COPD, and so we talk about treatment. Hi, we're going to treat your COPD. Maybe we're going to adjust your inhaler, but we didn't really give a thought to, could there be something else? Could there be an existing condition, almost like a comorbid condition that's making this COPD worse? Same thing with asthma. Maybe we're not thinking that this patient could have done so much damage to their lungs that now they're really less reversible than they used to be. Maybe beta agonists aren't having the effect. It could be that this asthma patient that's always had asthma is now looking and sounding like a COPD patient. Again, it's got to be top of mind. We need to be thinking about it in order for us to diagnose it. So the pathophysiology, just a little bit, but the classic COPD patient, we think about just that typical one. Due to exposure, right, over time, typically it's tobacco, but it could be other things. It could be environmental smoke. It could be cooking fire smoke, occupational exposure. Typically, the inflammation is neutrophilic. We think that's kind of the typical way to think about COPD. All patients have type 1 and type 2 inflammation, but which one predominates? Which one is the one that drives most of the symptoms? When they come in and see you and they're having an exacerbation, which one is behind the symptoms that are bringing them in today? The classic COPD patient, we think about neutrophilic inflammation. The onset is typically later in life, and there isn't usually a lot of atopic features. Again, this is the classic COPD patient. And they may not reverse much at all. If they have PFTs done, you may not see much of a change at all in FEV1 after they have a bronchodilator. So that's the classic COPD patient. So we kind of put that in a pile. Classic asthma patient often starts in childhood, although not always. There often can be other atopic conditions, maybe atopic dermatitis or eosinophilic esophagitis, something else that clues in to the fact that this is an atopic patient. And maybe they had the atopic march starting when they were a child with atopic dermatitis and have moved on to food allergies. That's kind of the classic presentation. They usually have pretty good reversal. That's how we get the diagnosis. So they respond very well to a beta agonist. And again, all the patients have all inflammation, but eosinophilic inflammation predominates. That's the one that is the driver of the symptoms. When they come in and they're coughing and wheezing, nighttime cough, maybe they cough every time they laugh, those symptoms are driven by eosinophils. There's still neutrophilic inflammation, but those eosinophils are really behind the core problem. And so these are the classic patients, and this is how they present. Okay, so now we have kind of in our mind the classic COPD patient and the classic typical asthma patient. So now let's merge them together. Let's think about what that might look like if both conditions are present. So first patient, COPD. They've had a COPD diagnosis for many, many years. You've seen them a few times and they're coming in. Well, what could that patient look like that would make you think, hey, they might have asthma COPD overlap? They could have high levels of blood eosinophils, something that a lot of COPD patients don't have, but up to a third will present with eosinophils over 250, which can indicate that inflammation is playing a big role. Maybe they have a previous diagnosis of asthma, and maybe it hasn't been part of their life recently, so it hasn't come up, and it could be in the chart somewhere back in the chart, or even not at all because it was in childhood. But they would say, yes, oh yeah, I had asthma as a child. I was somebody that was sick a lot and didn't get better. One of the things in the GINA guidelines last couple of years, they've really emphasized that when pediatric patients especially get sick, and then they have another illness a few months later, but they never really got back to baseline, never got completely rid of the cough, that's a significant risk factor for asthma. So you can ask your patient, now I know you have COPD, but as a kid or an adolescent, did you get sick frequently and then almost never get totally well and then you got sick again? Maybe this COPD patient has other atopic conditions. You look down and you see a little atopic dermatitis on their arm. That makes you think this could be a patient with other atopic conditions and maybe they've got asthma. And albuterol provides a big benefit. If they either on their PFTs or spirometry or they get a single nebulizer treatment and it's amazing, it's they say, oh my gosh, I feel so much better. That's just a clue, because typically albuterol is helpful for COPD, but it isn't often amazing. So if that's the case, all of these things would be kind of clicking in your mind to say, this patient who I'm very comfortable with having COPD, we've got that diagnosis, could asthma be playing a role? And again, if it does, that really changes treatment options, the prognosis, how you manage them completely changes if that's the case. Now we think about asthma patients. So again, a classic asthma patient, maybe a 48-year-old patient comes in and they have asthma and they're having a flare. Well, what if they're a smoker? They are 48 years old, they've had asthma since they were a kid, but they've been smoking since they were 18. All of a sudden, this COPD may be playing a role. What about occupational exposure or secondhand smoke? If they start telling you that albuterol just doesn't help like it used to, that's a clue, right? Albuterol should be very beneficial. At some point, they had spirometry in reverse, so it's historically been beneficial. But they start to say that, my albuterol inhaler just doesn't do it much, or I need to do 4 puffs to get the same benefit. That could be cluing you into the fact that there may be changes and this patient may be becoming more COPD-like. What about just increasing dyspnea despite optimal therapy? Anytime you have an asthma patient, you kind of know what's going to happen if they get on the right inhaler. If they get on an ICS LABA, you expect improvement. In fact, if they get on an inhaler that has an ICS LABA or a triple inhaler, and they really don't find much benefit, often that's not asthma. There's something else going on and we're missing it. So if these changes are happening, the person in front of you has asthma, but you're starting to think, could there be changes that indicate that this patient may be becoming an asthma COPD overlap patient? And then just widespread tissue remodeling and or emphysema. Maybe you have a CT scan. They have asthma, they got sick, CT was done, and it indicates that there's emphysema. All right, that's not something I would expect in somebody with just asthma, certainly not early on or younger patients. What about widespread tissue remodeling? They have scarring that's going on. All of these are what you might see in an asthma patient that actually has asthma COPD overlap. And if they do, it changes everything. The need for an accurate diagnosis is so important, but why? But what changes? So this patient has asthma, but they're morphing into a COPD patient, or they have COPD and they're a new patient to me and I've never talked to them about their history, but I find out they had pretty significant asthma as a kid. What does that mean? Well, patients with asthma COPD overlap, and this is both GOLD and GINA guidelines echo this, they have a greater burden of symptoms, more frequent and more severe exacerbations, and poor quality of life, more rapid decline in lung function, higher mortality, and increased healthcare utilization. In other words, everything, every aspect of their pulmonary disease is potentially worse. This is kind of the bad side, if you will, quote unquote, bad side of this, because you're taking two conditions, asthma and COPD, and you're kind of adding up all the bad things that are going on, all the pathophysiology that's going on, and you combine them. It's not like 1 + 1 is 2. In this case, asthma plus COPD is 3 or 4, because there is a cumulative effect. The asthma part can make the COPD part worse. The same COPD part can make the asthma part worse. They really do feed on each other, and there's this bump, if you will, in symptoms. And the outcome is they get sick more often. When they do get sick, it lasts longer. Their symptoms are more significant. They're much more likely to need treatment. Those patients with ACO, when they get sick, they get an upper respiratory, RSV or influenza pneumonia. They get sick. They get it. They get sick. And they'll tell you that. When I get sick, I'm done. This isn't something I just walk off and keep going to work. They'll become hypoxic much quicker. The mortality is worse, and the utilization healthcare costs are much more. So all of these are greater in that patient with both. So it just really emphasizes how important it is to think about this. When you have an asthma patient, be thinking, could COPD be a part of it? COPD, could asthma be a part of it? If it is, then I'm going to intervene and start changing the way I'm approaching this patient, because all of this stuff is happening. And if I don't intervene, then their prognosis is not nearly as good as it would be if they had either condition separately. Now, when it comes to the diagnosis, we're actually going to say that you have ACO. What do we do? The gold is pretty clear in this as well. Asthma, COPD overlap should be diagnosed in adults who have persistent airflow limitation and clinical features of both. All right. So they need that diagnosis, just like you would with COPD. At this point in time, we're still using this fixed ratio of 0.7. That could change, and I think it's likely to change in the next couple of years, but it is still a cutoff, and it's still an important number. When patients post-bronchodilator show this persistent limitation and they are obstructed, that's a patient that at least meets that checkbox. So now they have COPD, but they also have features of both asthma and COPD. This is a key where you key into the fact that you need to ask questions about what symptoms they have, their history. All of that will build up. And when they have both and meet the criteria for COPD, in this case, a fixed airway obstruction, they can then you're considering the diagnosis of asthma COPD overlap. In the end, ultimately, the diagnosis of asthma COPD overlap, it's going to rely on the history, spirometry or PFTs, and the assessment of biomarkers. Now, if you're in family practice or internal medicine, you may not be thinking biomarkers with these patients. But in this case, the only biomarker I'm referring to is eosinophils, which you get on most CBCs, hopefully. Hopefully you have that in the chart somewhere. Checking their eosinophil level. When those levels are high, over 250 for sure, that is a patient that you know has or likely has some eosinophilic inflammation, and it could be playing a role with this. It's got to be top of mind. It's got to be something we're thinking about. The next time you see an asthma patient that's older, one that smokes or has occupational exposure, you got to be thinking, could this patient have COPD? Could they have a fixed obstruction and the features of COPD? If a patient has COPD, do they have a history of asthma, other atopic conditions? Do they seem, if their eosinophils are high, then the asthmatic part could be playing enough of a role to bump them into this higher risk category. Okay, a little bit of a side note, a sidebar here, but I did want to mention alpha-1. Alpha-1 antitrypsin deficiency is something that is very near and dear to me. My family has it. I have two grandparents that when they married, they were second cousins, and they swear they didn't know it, but they both had a recessive gene. Their children, some of them got both recessive genes. My mom got both the Z genes, which are it's the most common deficient gene that we have. And so she was affected and passed away of alpha-1. I have one normal gene and one abnormal gene, so I have moderate disease. Alpha-1 is a deficiency. We are low. My family is low. I am low in this protectant. What that does is protects me from my own immune system. When our immune system attacks virally infected cells or bacteria, we digest those, and there's a breakdown process. Well, the good part should happen. We should do that, but then those proteases should stop. They should not continue to go and digest us, if you will. Without the protection, there's some breakdown of lung tissue with every immune event. Somebody that's very severely deficient, like my mom was, she had symptoms when she was 18. She remembers walking to get her diploma and having to stop and catch her breath. And that was unusual. And she said, I knew something was wrong then. So very symptomatic early in life. She was severely deficient, and so had very little protection. I have a little bit more. When you're deficient, that level is low, and there's digestion going on in your lung tissue, if you will. it's much more likely that you could develop COPD or emphysema. So it is a genetic emphysema, and lungs often look like the lungs of a smoker despite never smoking. The key with this is top of mind and testing, and that's what I want to encourage you to do. Alpha-1 is easily missed. However, the guidelines are very clear. Everyone with COPD should get tested. That's everyone. Anyone with asthma that doesn't completely reverse, any part of asthma that doesn't look right, if their medications aren't working, they don't respond, those patients, please do an alpha-1 test. And there are free kits available so that you can get testing done at no cost to your patients. It's confidential, no cost. You can test their family at no cost. It's life-changing. In my family, it changed everything because now we have family members that are being treated and doing much better. So get out there. Remember, it's a part of the patients you see. And if you do test for it, I promise you will find it. Okay. Now, the one big thing, this is, I think, if there is, can't really say silver lining, but if there is something like a silver lining, it's that patients with asthma COPD overlap have every therapy available to them. It's at least an option. Now, it may not be appropriate for the specific patient you're seeing, but if you think about asthma treatment options and COPD treatment options, when the two conditions come together, there is this additive negative effect. Well, the only good side is that every treatment is available to them. You need to be considering almost everything. And so with asthma patients, you may not be considering medications like nebulized therapy or newer therapies like ensifentrine. You might not be thinking that, whereas you might think some of those things for COPD. Also, we don't make smoking cessation nearly as prominent as we do with COPD. It's good data saying, like, if you have a patient with asthma, smoking cessation isn't brought up nearly as much, and talk to them about therapies. Rather, if they have COPD, though, we do. So with asthma and you're considering ACO, it just opens up the door. For patients with COPD, you may not be considering a biologic, although now we do have 2 biologics approved for patients with COPD and elevated eosinophils. So we do have some options, so it's getting more top of mind. But we may not have been thinking about it. What about working with an allergist? Somebody has COPD, we may not be thinking that, whereas with asthma, we might. But if you have a COPD patient that has atopic features, you may help them tremendously by working with an allergist and seeing what aeroallergens or environmental allergens we could impact with immunotherapy. So it's just one of those situations where there's a double negative. ACO patients have more going on that's negative. They get sick more often. They're more likely to be hospitalized. Everything kind of is worse. But on the treatment side, everything is open. There's no one medication type that you would say, no, that doesn't apply to them, like you might if they had asthma or COPD alone. Think about treatment options. This is not all inclusive. I just kind of put some of the most common things we think about. First line therapy, this again, with asthma COPD overlap, they are going to have all options available. And for many, a triple inhaler might make a lot of sense. A triple inhaler with a beta agonist and an anticholinergic and the steroid built in. That's not something you would necessarily think about for all COPD patients alone. If they have COPD and they have low eosinophils and they're doing well, we would be thinking LAMA-LABA and start with that and maybe stick with that for most of the time. With asthma COPD overlap, though, that's a condition where you would want to think steroids first and start them on a triple inhaler if they're not already. So it's just an option that can treat both the asthma and COPD side well. Add-on therapies like leukotriene receptor antagonists, macrolide therapy, which we are starting to use more in asthma, but it's been a treatment for COPD for quite some time. And thinking about oral prednisone. Now, we use that for both, but it is an option. And for patients with ACO, they are more likely to be responsive than if they just had COPD alone. And then the biologics. We have 2 therapies approved for COPD. We have more approved for asthma. In this case, with ACO, any biologic is at least an option, at least something to think about. And it may be more helpful than it would be if they just had asthma or COPD alone. And then advanced therapies like ensifentrine and roflumilast, those are things, again, we might not think about for asthma. And it may not be appropriate. The patient with asthma COPD overlap, this may not make sense, but it's something to consider. Because they have both conditions, the therapies for both are on the table, and it can be life-changing. Okay, big picture review real quick. We talked about asthma by itself and COPD by itself. We talked about how when they come together, It's an additive negative, if you will. I just made up that phrase, but there's a negative aspect to both. And the asthma part can make the COPD part worse and vice versa. So it's a combination that we don't want. But if it's there, we want to diagnose it and realize that we can treat and have more options available. So when I say it may not be a thing, it's not a distinct entity. It's not a syndrome, and it's not a diagnosis where you're taking that patient and putting them in a different pile altogether when it comes to the diagnosis and considering it. But when it comes to the treatment, they are very different. And so the importance of it isn't diminished at all by the fact that it's no longer considered a syndrome. And you've got to be thinking it. You've got to be considering asthma COPD overlap, or you're going to miss it. Now, in this case, the history will often reveal the diagnosis. You have to start at the beginning. So I would just encourage you, if you're not familiar with the patient, or if you've never done this, they come in with COPD, you want to say, hey, where were you born? Where did you grow up? Did you have asthma as a kid? Do you remember having significant allergies as a kid? You start talking to a COPD patient about their history and find out that they have an atopic history. They had allergies. They had atopic dermatitis. They have a couple of food allergies. Right then and there, you've got to be thinking, this patient has COPD, but could they have eosinophilic inflammation that's being a part? Could they also have enough characteristics of asthma that an ACO diagnosis is indicated? So go back and get as much history as you can and see how they're doing. For the asthma patient, your tobacco use, other forms of inhaled smoke, or anything like occupational exposure, take a step back and get their history. Find out what they've been doing. I just had a patient that said he's always said he's never smoked. And then he said, but I smoked marijuana every day for 25 years. And that never even came up. And he's an asthma patient. And I just had been probing. So you've got to probe and ask those asthma patients, what's your exposure history? Are you feeling like your medications aren't working like as well as they have in the past? Does albuterol not provide the benefit it did? Does it feel like your asthma is the same every day? Because there's usually a high variability. All these things make you think that there could be remodeling going on. There could be changes going on structurally to the lungs that now they have this fixed obstruction. And if you get spirometry, you see they don't change much. They are 0.7 or below, and the albuterol is not making much of a change. And they have a fixed, in this case, if you will, obstruction. And if that's the case, they are losing lung faster. They're sicker more often. When they get it, they are more likely to have severe outcomes. And the decline is greater than it would be if they didn't have ACO. And in this case, all of their respiratory options are available. And with these patients, again, all respiratory therapies are at least on the table. They may not be appropriate for any one particular patient, but think about the options for COPD. Think about the options for asthma, nebulized therapy, biologic therapy, using prednisone judiciously, hopefully, using macrolides. All of these things are options for the patient with ACO. And again, you may not have been thinking that, but if you take a step back and think, they have COPD, but I've just learned that they have a lot of features of asthma and a lot of atopic comorbidities. They've got things going on that I can treat and go after. And maybe I'll work with an allergist. Maybe I'll see if there's trigger avoidance that makes a difference. I hadn't considered montelukast. Maybe I'll consider that in the appropriate patient. Anytime you have a patient with ACO, the treatment options are not limited from the beginning, and it gives you more opportunity to change the progress and preserve lung function for these patients. Appreciate you taking part. Again, my name is Brian Biesick, and I work in Idaho in pulmonary medicine, and I'm always happy to help out if there's anything I can do. My name, Brian Biesick, my email is just brianbiesick@yahoo.com, and you're welcome to reach out to me if I can be helped. Thank you.